Well, I think we can go ahead and get started while everybody's hopping on. Welcome everybody to our February meeting of the Collaborative Care Special Interest Group. I was wondering how many new people we have on today. Anybody here, maybe raise your hand, your virtual hand, or your real hand, if this is your first time to be here. Oh, so I saw, is it Akia? Okay, Akia, nice. And Kathy. So Kathy works with me. She's right down the hall. I'm glad she's here. The other first timers. Well, as we kind of talked about last month, we have some new leadership on the SIG this year. Laura Sidari is my new co-chair, and Monica Harrison is the secretary. And we are grateful to Diane Powers, who was a co-chair with me in the previous years, getting this group up and running, and she's here today. And we are just happy to have everyone here. Normally what we do is we have a person who comes in and speaks about a specific topic related to collaborative care, shares their experiences, but really what we want to do is have it spark discussion and have us to be able to come away with ideas and learn from one another. So we really hope that as much as possible, this can be a cameras on venture where we can see each other's faces and spark conversations, ask questions during the presentation. And we also hope that we can, if you have ideas for things that we should talk about in other meetings, please let us know. Another announcement that we have is that if you saw on the listserv, there is the call for presentations for the CFHA conference that's going to be in October in San Antonio, right? Yes. I always want to say Austin, but it's San Antonio. Very excited. I haven't been to San Antonio in years, so it's October will be a great time to be there. So we're really looking for people who want to present some of the things that we've been doing, have this be a place either on our base camp or here to meet and talk to people about things you might want to present together. We want to be a place where we can share ideas and talk about those things too. And our speaker today is going to be our co-chair, Laura Sidari, who's going to give us some great tips and tricks for effective systematic case reviews and collaborative care. She's a psychiatrist who's been very instrumental in implementing collaborative care where she works at Cayuga Health, and she is also just a great trainer and talks really effectively, and I think just a really great communicator about how to do this in ways that makes it seem really simple, and it's not simple at all. So look forward to hearing about what you're going to teach us today, and I'm hoping to share the recording with my crew. Is there anything that you, Laura, or Monica want to add before we get started?
Monica, anything that you have?
Not for me, just that, hey, everybody that I gave in the beginning. I'm glad to see new faces on too, and encourage individuals to share with others who are embarking on their collaborative care journey to bring more of us together.
Sounds great. And, Tisha, Monica, if you see any chat questions come up, just let me know. Oh, Patty, do you have a question or something to say?
Well, I was just going to make a point that this systemic case review, it's one of those things everybody kind of skims over. It's like, oh yeah, just go have a meeting and It's kind of like a lot of things in integrated care. If we do it the way that we've done consultations in specialty mental health, for sure that psychiatrist is going to talk about everything and get bogged down in a total initial. So I think this is a real skill set, and it's a really good topic that you're doing today. So I just want to acknowledge that, because it's definitely harder to do than it sounds.
Yes, Patty, and you understand also as a consulting psychiatrist how challenging that is. And I think that's a perfect intro for this discussion. There's the basics, so like the evidence-based, like how you do this. And then there's like the practical stuff of how we actually do this in the real world with a patient with 52 different medications and maybe multiple medical comorbidities on top of depression, anxiety, or other psychiatric conditions they have. So the goal for this time is really to give you some tips and tricks for how to do this. And we're going to try to make a very complex topic a little bit simpler, to that point that Tisha shared. I think that's really important for us to try to find ways to take these difficult concepts and make them really practical for everyday life. I wanted to also just send a shout out for all the great feedback that we got on Basecamp. People volunteering for different subjects, putting ideas out there. We've got a lot of awesome different topics that we're hoping to explore in the next year and beyond. So continue to be active in Basecamp. And I'm going to sprinkle in some of those things that were shared in the appetizer discussion that we had related to this. If you have any questions in the chat or other things like that, just Monica and Tisha, let me know if there's any that come up. We'll also have a break about halfway to do some checkpoint questions to get some group engagement. So the main learning objectives we're going to have are really breaking down those basics to begin with. Who are the team members and what are the care components typically involved in systematic case reviews by the book? And then we're going to be discussing best practice as well as expert opinion recommendations for how do we actually facilitate in real life these different pieces. After having a break to ask some questions about kind of where people are at in terms of these evidence-based practices and their practical practices, then we're going to look at some real life examples. This is something I would say that we don't have enough out there of. What do these notes actually look like? What does a BHCM presentation typically look like? And I'm going to give you those from my perspective as a consulting psychiatrist. This doesn't mean this is the only way to do it, but my hope is with this discussion that you'll be able to see in real life what that looks like in my clinical practice, and then be able to apply and sort of translate that over to what works best for your own. So let's start out with the spectrum of psychiatric consultation. I think it's really important before we get too deep into this to know that no one size fits all for patient-related psychiatric consultation. And I really want you to be thinking about, as a key concept here, how can we use the minimum level of psychiatric consultation to meet the patient's needs? What we know is that on the spectrum, lower levels of consultation take the least number of resources and can serve the most number of patients. And they also hold the least amount of liability. This ranges from no consultation at all the way up to an established treatment relationship. And that might be that the psychiatrist is directly caring for the patient, or maybe the supervising provider, which by default, then they are the treating provider as well. At the lowest level of consultation, this is a curbside consultation. And it comes from that term of kind of like being on the curbside with your friend in the hallway, your colleague in the hallway as a physician, and just asking them, hey, what do you think about this? And this is actually something that in the literature and evidence base for integrated care to include, but not limited to, collaborative care has really been highlighted as a way to efficiently care for it from a consultative perspective, many patients. These are questions from an edification purpose type perspective. These are not patient specific, so they don't need to be documented in the medical record. But with the new E&M coding for AMA, this can be under the complexity of information interpreted by a primary care provider. So there are some pushes to possibly have ways of documenting these conversations in the medical record for that E&M coding for PCPs. We then have this indirect but more formal means of communicating from the consultative perspective, where the psychiatric consultant is making patient-specific recommendations but not seeing the patient. And this can be through electronic monitoring, like with a registry or a caseload that you're looking through the different individuals and maybe not making specific recommendations, but seeing that full picture. And then we also have the electronic case review. The most involved means of consultation is the direct evaluation. And that's a formal direct evaluation. So the psychiatrist is meeting with the patient, not seeing the patient through the eyes of the care team or the electronic medical record. And this takes the most amount of resources and holds the greatest level of liability. This is really helpful, especially for your most complex patients whose care needs can't be met by lower levels of consultation. When we think about the SCR, it's going to involve these two main areas. I see we have some things coming into the chat. Are there any questions that are coming up?
Nope, no questions for you, Laura, just all base camp related stuff.
Sounds great. All right, so now let's break down what are the basic components of the SCR. So we have our care team members, and the primary participants in the care team are going to be the behavioral health care manager and the psychiatric consultant. You can have other team members that are involved. You know, I have often PA students, NP students, residents that'll get involved. You can have the PCPs join periodically, but really by the book, the systematic case review, the key main participants are going to be the care manager and the psychiatric consultant. There's a lot of different ways this is set up. The model with greatest fidelity is you have one behavioral health care manager to one psychiatric consultant. We'll talk a little bit more in a moment about the amount of time and kind of time matching for that. Some of the key things are also to think about what is the definition for each of these care team members. You know, I've often come up like who can be a psychiatric consultant, who can be a behavioral health care manager. And I would encourage, if you're having those questions, go to the AMA CPT manual as a good place to begin. Under that, they define the psychiatric consultant by nature needing to be a medical professional, trained in psychiatry, who's qualified to prescribe the full range of medications. So most of our psychiatric consultants are going to be consulting psychiatrists or psych NPs. There would be concerns potentially with a PA under that because they're not authorized to prescribe the full range of medications. And the psychiatric consultant's job is to advise and make recommendations as needed for psychiatric and other medical care needs. So keep that in mind. It's not just limited to psychotropic medications, the things that we're going to be reviewing in the SCR. And they communicate to the treating physician or other qualified healthcare professional through the care manager. And the psychiatric consultant typically does not see the patient or prescribe medications except in rare circumstances. With our behavioral health care manager, they're a clinical staff member. They are typically a master's level or sometimes doctorate level educated or specified training in behavioral health. I can say in my clinical practice, I see more master's level. I don't typically see doctorate level behavioral health care managers. And they provide care management services as well as assessment of needs, all in consultation with a psychiatric consultant. And these services are provided both face-to-face and non-face-to-face, and that includes the SCR with psychiatric consultation. There is a notation also that they could be a professional with additional specialized mental health training, behavioral health training. So that's just another consideration as you're thinking about who your care manager is. And then what do you need to be able to do systematic case review? So keep in mind, this is targeted registry review. This should not just be a list of cases to review. Part of this is the psychiatric consultant seeing the full caseload, reviewing the full registry, and then targetedly reviewing cases that meet certain criteria or have certain needs. So it's a very structured format, and it's focused discussion of select patients. So this allows us to meet the care need with collaborative care, both for population health level, as well as patient-centered care. So keep that in mind. That's a common area of confusion. I love this diagram from the AIM Center that talks about for behavioral health care managers, how do we choose a caseload size? And if you've not read this article from Dr. Bauer, and her colleagues, I really highly recommend doing that. So this gives the idea that for systematic case review, it's not going to be one size fits all. I've heard in some care systems, like we had our oncology colleagues come last month, as small as 30 patients in a caseload size, all the way up to 90 or 120. I would say that I don't typically see 120. Most kind of care systems have a level of complexity beyond that low level. When you're thinking about systematic case review and the timing, you want to think both about the number of patients as well as the complexity. So, this guideline really gives it by time. I have to also say, in clinical practice, you also need to consider the complexity, how many patients are going to need more of an expanded in-depth review compared to a briefer review. We'll talk a little bit more about how you determine that in your systematic case review, who needs what kind of review. But just, kind of giving that this is an example of an area of common confusion, but how do you find that sweet spot with your psychiatric consultant? Getting organized. This is another area that commonly comes up. Who needs what open during systematic case review? Who does what part of the job? I like to equate this to a dance. The care manager and the psychiatric consultant are doing this dance together. And if one partner is stepping on the other one's shoes, things don't work out so great. So what I have found, as well as what the evidence base supports, you first need a means of communication. My means of communication preference is over two-way video, audio, telehealth. I do those all remotely, but some care teams, they'll also do that in person. The key thing is that you need to be able to hear each other as well as be able to see one another so that you can read those nonverbal cues. That's really helpful. I have one care manager that we don't do video because it's very distracting to her, so that would be an exception. But for the majority of care managers, that really is what works best for us. Also, you should have open your registry, and both of you have open the electronic health record. There are some psychiatric consultants that will purely have their care manager go to the electronic health record and look things up. I do not do that. There are notes in there that only I am going to really know how to interpret, consultation notes that may be applicable. I don't always need to look at that, but sometimes I need to. Taking a look at labs, taking a look at medications. I'm able to do that very quickly. So I've got that open, and I don't really emphasize that for my care managers to present to me on. I'm going to do that with them in real time as we're both discussing. It's also important you both can see that registry so that you see not only the patients who need to be reviewed, but also the entire registry, so that maybe if there's a patient that my care manager missed, or I've got a concern, there's a patient with really low scores. Why do they have really low scores and they're still in care? I then can bring them to review even if they weren't flagged. And then there's also the timekeeping piece. Keep in mind, this is how we translate over our cognitive work in collaborative care model. It's based upon billable minutes. And so you want to be tracking on that time you're spending discussing, time you're spending documenting. You want to make sure if you're talking about patient, you are documenting that, with the exception of early training where maybe there's a clinical question that's not patient specific. Every minute that you spend discussing with the patient should be translated over into billable minutes. Monica had raised a nice comment on Basecamp. She indicated when the psychiatric consultant was rushing and did not seem personable, it did not build team cohesion and increase my comfortability in asking questions for further clarification. So keep that in mind, that we're tracking the time. We're wanting to match that level of time to the care need, but we also want to be thoughtful about not inappropriately rushing that too much. So if you're only spending about a half an hour reviewing many, many patients, maybe that's not enough time to really have that quality relationship that's needed to deliver the care. Ben, also shared on Basecamp, we had strong participation from PCP providers, which led to many practice-wide benefits, but also a need to manage the consultation for effectiveness. So we want to be thinking about too, as we're providing these consultations, not just what is the care manager needing, but also what is our PCPs needing as we're having these conversations. In terms of what the care manager typically has open on their own, we use an agenda document. Other teams, they might have those features in their registries. And in my care system, we typically have the care manager manage that agenda. And we do that in real time. So as we're removing patients from the agenda, they're getting deleted. If there's a to-do, that's getting added to the agenda. That agenda is dynamically updated throughout the week by the care manager. And if I have a case review with a PCP, I might add something to that. But during systematic case review, that's something my care manager typically navigates. And then on my side, I also have both a document template as well as a free type approach that I use. So I'm ready to document. I'm ready to go with those quick templates for the care needs that we commonly have. I have quick templates for engagement notes as well as for safety flag reviews. So be thinking about what kind of notes come up a lot and are easily templated. Keep in mind a template doesn't work well for everything. So kind of balancing the benefits for streamlining assessments while also sometimes it's just faster just to start typing away as opposed to going and looking for a template. So in terms of systematic case review best practices, so keep in mind in an SCR of 1 to 2 hours duration, this article from Dr. Bauer nicely outlines this. What we typically have is this bookend effect. So you have a brief check-in in the beginning, which is happening to start, and then you have a wrap up at the end. Within the middle, this is where we're doing our targeted case reviews. All of this time should be billable. If it is not all billable, you really need to take a look at your processes to see where there might be inefficiencies and making sure you're doing what's needed in that time. Brief check-in typically involves setting the agenda, looking at the agenda that's already there or quickly setting it if that's the preference for your care team. This is also where you might have clinic updates. I'll typically update my team or my care manager will update me about if we're going to be out for a period of time. If there's a change in billing and coding guidance, if there's a situation happening with the clinic or maybe a change in PCP. These are non-patient specific updates. For systematic case review, you really, typically want to emphasize case notes and discussions for the following. But keep in mind, this might change based upon the care needs. If you're caring for a specialized population like oncology patients, there might be different sort of clinical needs than a more general population. So I typically outline this according to what Dr. Bauer recommends, which is clinical questions first for patients who've been in care for less than 60 days. If there's clinical concerns like a safety issue or patient was recently admitted, the inpatient unit or seen in the ER, I do that next. If they're not improving, that's next. Engagement difficulties. Readiness for graduation, we don't do everyone, but if there's a patient where maybe the relapse prevention plan is a bit tricky or they don't really know what to do for graduation, we might review them there. And then other clinical or administrative needs. In New York State, there's a requirement, for instance, for Medicare patients that they be reviewed every single month. So we have a standard note for patients who clinically don't need a review. That patient was identified for review per Medicare guidelines. No clinical indications for psychiatric case review at this time. We'll continue in CoCM with the care manager working towards depression and anxiety goals. That would be an example of other clinical and administrative needs category. And then we always do a wrap up. It's really important not to forget about celebrating successes. A lot of the targeted case reviews are going to be connected to problems. Who are your problem children in collaborative care? Who's the patients that are really the pebble in the shoe for the care manager? So don't forget to take that time to really celebrate what's going well. Also confirm next to-dos. Sometimes I'll have to-dos as the consulting psychiatrist. Sometimes the care manager will have to-dos. You want to try to maximize all of the care that you're doing, though, in those case review sessions. You should not be spending exorbitant amounts of time prepping cases before or wrapping them up after. If you're doing that, I encourage practicing with a trained professional or like practicing on your own how to do more effective and efficient psychiatric case reviews. But there sometimes are to-dos to follow up with afterwards. And always verify the next SCR. I can't tell you how many times in the beginning, would show up one of us or the other, and it's like, oh, forgot the person was on vacation. So it's always nice to kind of have as the bookend, just making sure that those things are set. All right, this is something that I've learned. I really recommend, if you haven't read this article by Benzer et al., go take a look. So, one of the biggest challenges I would say that comes up with SCR is like, how do I balance having a really systematized process for case review, standardized presentation for the care manager, like really set way of doing this, with also, this patient doesn't fit into that box. This patient is highly complex. They've got lots of care needs. Maybe they're even, seemingly outside the scope of collaborative care, but how can I meet their care needs within the scope? So I would encourage using this process from organizational theory applications for integrated care to help you with finding that balance. Where possible, it's really helpful to use standardized coordination. So this is considered impersonal and codified communication. So this would be like having your standardized process for how you have your care manager present the case. It's very predictable. We need to know that for every patient. Those are the sort of things that should be very standardized. That helps with efficient communication. And this allows you to review many patients in a case review time. AIM Center recommends, for instance, 6 or more case reviews within a given SCR. So we're not going to want to spend in the 2-hour case review only reviewing 1 or 2 cases. We really want to make sure that we're optimizing that. That's an important piece. But that's not going to work for everyone. So we want to also be thinking about that interpersonal communication. Where is this also an area that the care managers may be struggling, or the psychiatric consultant is struggling? Where is there a patient-specific care need that maybe we need to adapt or massage a little bit of the information that we're gathering? Maybe we need to meet back next week to pick back up on this case review because we need the care manager to gather more information related to trauma or ADHD concerns or mania. This is helpful for determining when that's needed. And this allows you to be adaptable to the complex and unique patient care needs that can often happen when you're caring for a community population. This is more time consuming. These reviews are going to take longer than the standardized 5 to 15 minutes that's quoted in the literature. I've had some case reviews, for that case I'm describing, 54 medications, many comorbidities. That one took about 35 minutes. When I first started doing CoCM systematic case reviews, that one would take me about an hour. So we want to be able to decrease the amount of time, but recognize we're going to have to expand that amount of time for certain patients. And this helps to optimize quality over quantity. There's this approach that I really use as kind of a guiding light for myself, and it's called purpose-driven case reviews. And this is really driven by the question. And it allows you to match the level of consultation to the care need. I have to say, this is easier in theory than it is in practice. So keep in mind, have a little bit of just kindness with yourself, that striking this balance is a constant work in progress as opposed to something to strive for perfection. So we're at the half-an-hour mark. I want to just take a few minutes. I'm going to stop with sharing for a second, and I'm going to put these into the chat. And I want to just kind of get a pulse on from individuals here the following question. Oh gosh, that didn't work as well as I expected. All right, the first question is, for care team members participating in SCRs, how do your processes align with these best practice recommendations that I've outlined? Do they align well, or are there areas of difference? People can type in the chat. They can answer whatever you think is best. I see some people here, so I'm just going to ask Kathy to begin with. I know, Kathy, you're new to the team. Can you give me any thoughts from your perspectives?
I think we could be a little bit more efficient in the case presentations. Working in some time for business doesn't always happen. We kind of jump in. We can get bogged down on new case discussions, and we are unable to run through our case review on a routine basis. So, it's working, but we could improve. But I like the presentation you just did about kind of structuring the time.
Yes, and as Patty put in the chat, time management is tough. So that is a very common challenge. How can we stay organized, right? That systematic sort of piece versus personalized. Anybody else?
I'll say, as someone who doesn't necessarily do it, but someone who witnesses it, sometimes like in our clinic where the psychiatric consultant and the care manager are actually in the same clinic, it becomes less structured because they're just sitting there and there's like chat, but they don't actually sit down some days and do the case review. So
that's a great point. And that's why I really emphasize that part of the sandwich every minute in that sandwich between brief check-in and wrap-up should be billable. If we're finding that that's creeping maybe towards more of like the bread of one side or the other, that's an opportunity for us really to kind of reel ourselves back in. It's always nice to have those personalized conversations, but we want to make sure that we're not drifting. So Ryan put into the chat, I feel that ours is going well. We like the agenda idea and use email to send the psych consultant the patients we would like to discuss 2 days before our consult time. You know, it's really helpful to have on the radar early the patients you know that are going to need case review. So that is a great idea, you know, using your agenda in a way that's helpful proactively to kind of prime and get ready for that. You want to make sure that you're still using your registry to see the full population health perspective, but it's really, really helpful to identify patients that you're going to need to prioritize or absolutely need to be reviewed. Patty put, thinking about care of the population is different than our usual focus on individual patients. Absolutely. This is a different role than a traditional psychiatrist. It's not a great fit for everyone, and it's also not comfortable for many of us when we get started. So, you know, kind of like thinking about that, the similarities and differences from other care roles is helpful. Monica shared, having done them previously, planning ahead is key. Agree. And then Carla shared, we train the BHCMs to really be the quarterback. I like that approach, right? They're really like the one leading the agenda. They're leading the SCR. They're keeping us on track. That is such an excellent point. Ben, I see you unmuted yourself.
Yeah.
Go ahead.
Question. So one of the things I noticed is that, and it's understandable that the patients that come into the SCR are always the more severe or more at risk patients, but we've also found that there's some real value in focusing on some of those folks that are not as severe too. Can you talk about sort of how you manage that sort of severity spectrum?
Yes. That's what I really liked about Dr. Bauer's article, that it kind of like has priority, like the patients you absolutely have to review at the top and then a little bit lower down. So, you know, keep in mind, who are the patients we cannot leave SCR without reviewing? Those are the ones you want to review first. So I would use timing and organization of the SCR for prioritizing those who need it most. But don't forget about the patients who maybe need it on the lower level, but still would benefit. So those are patients who aren't engaging well in care. If they're not engaging, they're not going to get better. So even though those are really quick reviews and a little bit lower down on the list, it still has great clinical importance. Patients who are getting ready to graduate, there can be tremendous value, especially if, let's say, returning to CoCM in the future, if these indications might be there, would be an issue. There's also a common misconception that every patient is needing to be reviewed, whoever enters treatment, or every patient who's leaving care needs to be reviewed. I want us to be thoughtful too that, you know, patients who are doing well, that there's not a clinical indication for review, we don't need to review them, but we also shouldn't shy away from those without like super, super severe needs and you know, minimize that care need, even if it's maybe less acute. Does that make sense? Great question.
Thank you.
Let's see. Caitlin said, so far with my experience, our psych consultant did not have access to the registry. That is concerning. If they don't have access to the registry, how are they documenting? I can currently document all of my cases. So you can think about the care manager documenting that, but often it can be really helpful for your consulting psychiatrist or psychiatric consultant to be documenting. At minimum, they're going to need access to the registry during the case review. So screen sharing can be very helpful so that they can see the full case and they can have you toggle. But that would be an area definitely to look at, making sure that they get access. Great discussion. All right, we're next going to continue on to how do we actually do this? And I want to share that this is something I don't see us having enough out there. So I'm going to show, this is how I do it with my team. This is how I've translated over the best practice recommendations. And here's some common examples of how this plays out and works. So let's get started. You know, there's a lot of different ways that different health systems have set up the behavioral health care manager presentation template. The things that are common are you want to make sure that these are efficient, They include the information that are most needed to be had to answer the clinical care questions, and that these also don't get too bogged down in details such that the psychiatric consultant can't keep up if they're concurrently documenting. For some of my care managers, I have them just go through that very quickly and I'm concurrently documenting. For some of my care managers, we'll take a pause after each section, and that seems to work better. I would say try it out different ways and see what works best for you. For my care team, we always start out with patient identifiers. So what's the patient's name, age, preferred pronouns, and diagnoses in CoCM? What's the reason for review? So this is going to help me as the psychiatric consultant immediately hone in on what is the minimum need to know for this patient. So is this a clinical question from the PCP or the care manager? Is this a safety concern like an elevated item 9, elevated clinical assessment safety status, or a CSSRS elevation? Is this somebody who's not improving after greater than 60 days of CoCM treatment? Is this patient not consistently engaging or hasn't engaged at all within the last calendar month? Is this patient ready for graduation, or is it something else? Having your care manager state this right from the get-go helps to frame all of the rest of the discussion. This is an area that I would say I've adapted the most for the care needs of my team. I have found myself, if we don't have this part of the structured, kind of presentation, asking the care managers, why were they recommended for CoCM care? What is their adherence to BHCM check-ins? What's their status in the treatment to target goals? Are they not setting goals at all? Or maybe are they not meeting them? Or are they doing very well? What is their adherence and tolerability to prescribed medications? When was their last PCP visit? And when is the next PCP visit and next BHCM check-in? This is something that kind of under the standard templates will be under summary. It leaves a lot of room for interpretation, but this is what my care team has found to be most helpful. Then there's depression. And under the common guidance, most recent PHQ-9 score is in there. But what I have found over time is it is also very helpful to find out the initial PHQ-9 score. And then for the care manager to also comment if there's like a notable trend. So this patient has had up and down scores throughout treatment, or they've been gradually improving. But at minimum for every patient, it's helpful to know the initial and the most recent. Same thing for anxiety. And then I have the section safety and severe. Every patient, I want to know at minimum what's their PHQ-9 item 9 score, or if there's any other, clinical safety concerns like the CSSRS scores positive, or maybe they have warning signs for death by suicide. What is their substance use status? And in particular, alcohol, cannabis, illicit, tobacco, caffeine. Think about also for your care system, what are the common drugs of use? Is psilocybin really big out there? Put that in your standard review if it's a common problem across your care population. And then also, it's very important to have current and history of mania and current and history of psychosis, both as markers of severity, as well as the fact that these are common things that can change the direction of medication management and care planning. In terms of my psychiatric consultation templates, these are the ones that I use. I have in here in yellow the things that I would expect the care manager to try to have prepared for every patient, but you can notice that not all of these things are part of the standard presentation template, okay? So, when I do this, I always have in here a disclaimer about what the review includes and what it doesn't, the fact that I'm not seeing the patient face-to-face. I'm also going to have in here, these are the sections that we're having them present on, but I want them to also know and be ready to answer if there's trauma, ADHD, sleep. I can look at the medical conditions, but oftentimes patients will say, my Crohn's disease is a big problem or something like that. So having that on the radar, and then eating and physical activity. Psychosocial is another area that's helpful, with focus on current psychosocial needs more so than childhood history, as we might do with a traditional therapy relationship. I also have these brief templates, and so these are very helpful. I have a safety flag case review template, and these are the components that I have in there, and I have an engagement problems case review. These used to be something that I would pull up and just copy and paste into the registry and start typing into. Now I've got them memorized, so I am using this as a mental template as I'm having the behavioral health care manager do that, as opposed to copying and pasting these in. Really, at this point, this is the only one that I'll copy and paste in. I will also typically ask my care manager at the beginning, do you expect this to be a brief or expanded review? And what I'm getting at by this question is, do I need to copy and paste in this long template? Or are we going to be looking more so at something like this? Some of those are self-explanatory, like if it's an engagement problems case review, but it's a little bit more questioning if maybe they're not improving after 60 days. So let's look at a few examples. And so this is going to be an example of a brief review. So, serving as the care manager, presenting to my psychiatric consultant, Sam Smith is a 19-year-old male assigned at birth, preferred pronouns they, them, who's a college freshman diagnosed in CoCM with MDD and GAD. I'm in the process of further also ruling out ADHD with them. We're reviewing their case due to continued elevated PHQ-9 scoring in CoCM after greater than 60 days of treatment. They're currently treated with sertraline 100 milligrams daily, which they report taking every day as prescribed without any side effects. They report this has been somewhat helpful for anxiety and depression, but they are continuing to have difficulties with sleep, concentration, and organizing activities of daily life. They have been consistently attending our check-ins. They've done well with decreasing number of panic attacks per week through through our treatment to target goals. However, they've not made much progress with improving wake up and sleep consistency goals, even though we've been working to simplify these. And unfortunately, I have all of the pictures of people right there that I can't move. All right. And we've, okay, they've had trouble in particular sticking with decisions on a nighttime routine. They follow up with the PCP in 1 week. Most recent PHQ-9 score of 11, moderate, which is the same as their initial score. GAD-7 scores have improved in treatment from an initial score of 13 to a 7, mild. PHQ-9 item 9 score 0, no acute safety concerns across my clinical assessments at check-ins. They have denied a history of symptoms concerning for mania or psychosis, and I have not seen any symptoms of these concerns across their check-ins. They report drinking 1 regular cup of coffee once per week, but otherwise they deny tobacco, alcohol, cannabis, or illicit drug use. So some of the things that I see here, that are of consideration are, they're on a moderate dosing of sertraline. They're taking it, but they're not having complete coverage of symptoms. I'm not seeing significant substance use contributions or safety concerns. They've got follow-up coming up pretty soon. So I'm thinking that this is going to be a more brief review. I'm not going to have a lot of additional information that I'm going to need to gather. The things that I gather, though, would be looking at, is there a medical condition? Have the labs recently been completed? So I see they've been completed in 6 months or unrevealing to potential contributions to presentation. The thing that also sticks out to me is right now, this patient's in the middle of an ADHD assessment. So I'm probably not going to make a lot of medication recommendations. I'm going to want to see what happens with this ADHD assessment. And then we come back to take a look at what should we do with, the sertraline. So in this sort of case, I might say recommend holding on any major psychotropic changes at this time until further diagnostic clarification has been completed. In the interim, recommend at this time continuing to prioritize adequate trial behavioral interventions to help with target anxiety and sleep. Consider expanding targeted goals with behavioral activation to help with the depression, which seems to be improving less. So again, this is not intended to show you this is the exact clinical recommendations. It's to show you how I think as a psychiatric consultant of when I need more information and when I don't. Here's another example. Here's a brief engagement note. So Michael Stern is a 14-year-old male, prefer pronouns he, him, diagnosed in CoCM with MDD, single episode moderate. We're reviewing his case due to engagement difficulties in the last month of CoCM. He started CoCM 3 months ago. He last checked in with me a month ago, and I've been unable to reach him despite 3 outreach attempts. I tried twice to patient and 1 to mom, because again, this is an adolescent. This has been a pattern for him since he started CoCM, and he's had similar difficulties with consistent PCP visit attendance. For PCP visits, coordination with mom has been helpful in preventing no-shows, but attempts by me to call mom and patient have not been successful in helping him check in this month. He has not been open to restarting escitalopram or other antidepressant treatment previously offered by PCP due to, quote, not wanting to take medications. Although treatment records from PCP describe his depression as better with antidepressants. He's been difficult to engage in sticking to any treatment to target goals, even when we try to simplify them. He does not currently have an upcoming PCP visit scheduled. Most recent PHQ-9 score of 12, same as his initial score. Most recent GAD is 9, same as his initial score. Item 9 on PHQ-9 is 0. No acute safety concerns identified across our check-ins. He has denied a lifetime history of suicidal thoughts, behaviors, or intent. He has denied alcohol, cannabis, tobacco, and illicit drug use across our check-ins. He's denied a history of mania and psychotic symptoms and is not presented with concerning signs or symptoms in these check-ins. Mom is confirmed no known family history of bipolar. So what I'm looking for here as a consulting psychiatrist is he not engaging because of severe psychiatric symptoms? Is he not engaging because of risk for death by suicide? If there is a reason we can find for him not engaging, what is it? Because maybe we could target that to overcome. I am not needing lots and lots of clinical information here. I'm really needing targeted information about why is this young man not engaging and what can be done to overcome it. So here's another example where I'm really not going to need additional clinical information. The presentation from the care manager in 1 to 2 minutes is enough. So this similarly would be a review that takes 5 to 7 minutes. Recommend BHCM attempt one final outreach to a patient's mother facilitated by the office front desk because, no problems with check-ins with mom, scheduling with mom with PCP visit to try to re-engage the patient. If unable to re-engage patient via this method, recommend advancing CoCM deactivation procedures. We call deactivation instead of discharge because keep in mind, discharge is more of a permanent kind of thing. So think about that too. You want to kind of have it be that they're turned off or they fully discharged. If able to re-engage patient, recommend considering a next check-in of a joint visit with patient and mom to try and clarify barriers to regular check-ins. If patient motivated and amenable to continuing in CoCM, recommend incorporating treatment to target goals to help them overcome engagement difficulties as a part of the care plan. All right, and then we're going to finish with an expanded review. How do I determine when that's needed? So we have Kimberly Jones, who's a 27-year-old female, preferred pronoun she, her, diagnosed in CoCM with GAD and MDD recurrent moderate. We are reviewing her case due to continued elevation in GAD-7 and PHQ-9 scores in the last 60 days. She started CoCM 4 months ago for mixed depression and anxiety, which has worsened since starting a new job as an IT support technician. She's been checking in with me regularly and has experienced improvement in her depression symptoms with behavioral activation interventions and her antidepressant. Her anxiety has remained roughly the same. She's prescribed sertraline 50 milligrams daily without current side effects, but did have some stomach upset during the first week of initiation. She reports benefit taking her medication every morning now with her breakfast. Her PCP started her medication 2 months ago, and she has follow-up next week with her PCP and me. Her most recent PHQ-9 score yesterday was an 8, improved from an initial score of 17. Her most recent GAD-7 score was a 13, similar to an initial score of 14. Her item 9 on PHQ-9 was 0, and she denies a lifetime history of suicide intent or behaviors. She reports increasing alcohol use in the last 2 months to, quote, try to cope with my anxiety, described as 2 to 3 Long Island iced teas before bed 5 to 7 days per week. Previous to this, she described use as a rare mixed drink approximately once per month. She denies cannabis, tobacco, or illicit drug use. She avoids caffeine. She has denied a history of mania or psychotic symptoms and has not presented with concerning signs or symptoms at check-in. No acute safety concerns otherwise across my clinical assessments. So what I'm seeing here as the care manager is presenting this. This is sub-optimized sertraline. So maybe that's explaining the anxiety. Maybe this is somebody with a trauma and stressor related disorder. So I'm going to ask them a little bit more about trauma. What about the alcohol here? Maybe this is an alcohol use disorder that's evolving. Keep in mind, Long Island iced teas have a lot more alcohol in it than, a lot of other options. So maybe this is somebody who also is not realizing the amount of use, and that's why the anxiety is there. So this is an example of somebody that I'm going to need more clinical information to provide care recommendations. So this would be one that I would do an expanded review on. And some of the things that I would ask a little bit more about, what's been their pattern of depression across the years? So asking the care manager about that, there's been an episodic pattern of depression reported since college. I also would want to know a little bit more about the anxiety. So there's this baseline of generalized anxiety described beginning in teen years, but first became problematic during college. Trauma, denies the history. ADHD never diagnosed, reportedly did well in grade school, denies concentration difficulties outside of times with problematic anxiety, denies family history of ADHD. Want to ask about sleep? I'm going to take a closer look at medical conditions. And I also see no lab work in the last year. So I don't know if the liver is doing okay, if there's other markers or sequelae of alcohol concerns. You know, I asked the care manager about pattern of use, did not know about the pattern of alcohol use in college when first experienced depression or anxiety. So it's also important, even if you don't have that information, put that there. Don't have your care manager feel badly if they don't get everything. Just put it in there if it's not gathered. That'll help to inform your care recommendations. And then I would gather a little bit of psychosocial history. And this is where a treatment history would be really helpful. What's worked, what's not, what have they tried? And then these case recommendations may be a little more involved. When you have more information for a patient, it can be better to like kind of have a little case review summary. So this is like a typical case review summary I might have. I typically write this as we're going through the case review. So I'm going to start putting little tidbits up of what sort of my conceptualization of the case is to help organize my recommendations. And this is the type of case that would be helpful to have sort of a roadmap of recommendations. So you don't want it to be exhaustive, but having a few different things. So here, for this sort of case, I would focus on making sure we get some closer monitoring and assessment for alcohol. Consider further optimization of sertraline because, you know, really those higher doses are needed for better control of anxiety. And this would be a good patient to continue in CoCM. This is not somebody at this point who's needing specialty level care. We're still needing an adequate trial of treatment. So I think, you know, some of the things to think about as we finish up together, what are common challenges that come up for the psychiatric consultant and care manager related to systematic case reviews? And think about what should a BHCM be doing ahead of time versus during review to help facilitate an effective SCR. That prep that was brought up can be very helpful to help organize your time so that it's streamlined, especially if you're expecting a case to be expanded. How do the BHCM and psychiatric consultant balance it, providing enough information to be helpful with also completing enough reviews during SCR? So use that purpose-driven approach to help with that. And what do I do if the psychiatric consultant or I feel uncomfortable with the flow, speed, and or outcomes of reviews during SCR? You know, these are all very common things, and keep in mind that with the relationship. All right, we're going to stop there. Let me stop share. What do you all think about those questions or other questions?
Laura, I don't have a comment on that, but just the notes that you do as the psychiatric consultant, or at least one that I caught, looked lengthy. And so I'm just wondering how to keep psychiatric consultants engaged in this if there is a lot of documentation attached to it.
For the expanded reviews, yes. Those are going to take a little bit longer if there's a lot to do. But if you notice the engagement notes and, you know, kind of like there's like brief notes also for not improving, those don't all take so long. So most of my notes, I would say, take about 5 to 15 minutes. We're not going to have a lot of those expanded reviews, but for some patients that's needed. Think about also the time that's spent in your indirect case review time compared to what would be spent if you're having to do a one-time direct eval, and all the scheduling that goes into that and the coordination that goes into that. So it's about finding that tender balance between what can we do at this level of care to adequately meet the need with what sort of needs more. With that approach, I typically, out of 1,000 patients, only do 5 one-time evals. So thinking about how can we train psychiatric consultants to be able to do enough and exhaust that level of indirect eval while also that's not every patient. That's not most patients. As I tried to show with that expanded review, there's certain indicators that show I need more information, especially if there's medical complexities or substance use complexities, or what are some other diagnoses that may be explaining that. I don't need to ask every patient about trauma, ADHD, sleep. I don't need to ask every patient about psychosocial history, treatment history, just those select patients. So the goal here is to help level set with your psychiatric consultant. There's going to be times that you're going to need to have more involved documentation and other times less. Keep in mind, I'm still learning myself too. And so this is like a tender balance too with like working with certain PCPs. Some of my PCPs want that long roadmap. They want like all of the things of first, second, third, fourth. Others don't. They're really like, can you just give me like one recommendation at a time? So I also, as part of that, am looking at who's the PCP, what do I know about what they like, what do I know that they don't like? And so if they don't want a long review, I'm going to be much shorter. For shorter reviews, expect that you're going to have more times that you're going to review them until they get better. That can be really great if they're very simple, just having those sort of stepped up brief reviews. That is not good for a patient with lots of comorbidities, very complex. It's much better to have that more in-depth kind of like comprehensive initial case discussion. But that's this is a common challenge with psychiatric consultant training. This is a common challenge in general with like providing this care. But I would say, with this, it's part of also why we need to support one another in this process of when am I writing too much and when am I writing too little?
Thank you. I appreciate it.
Other things in here, dot phrases can be your friend too. Yes, especially if you're noticing there's like things you're saying every single time. Carla, in response to qualitative data feedback gathered from our PCPs, we adjusted our suggested PC documentation template to include the recs at the very beginning of the note. That is what I do too. So I showed kind of the reverse, more so to show like what extra information I gathered and then how I conceptualized it, but that is actually how the notes show up. My recommendations at the top and then everything else at the bottom, because the PCPs are not going to want to read about that, but when I have to come back and review that person again, because maybe they're not improving, I want to know what that is so that I don't have to ask the care manager that again. That is an excellent point. Keep the note as brief as possible, but include provider education, decision-making factors brief, and titration schedules. That is also a challenge. Some providers need less information, some providers need more. If, I have some PCPs, they don't feel comfortable even prescribing Prozac. So those individuals are going to need a little bit more, like even just titration sequence about higher dosing versus lower dosing of SSRIs for various conditions. So always try to put that brief psychoeducation there and match it to the level that the PCP is needing, if you know their level of kind of comfort and awareness.
Great, thank you. That was a lot of information in a short amount of time. I think very helpful. I know our team, I look forward to having this recording to share with our team and to kind of think through pieces of this and how we can do better and keep evolving. This is a very it's a new process and we're all learning together here. Well, thank you, everyone. Any last things that anyone wants to say or announcements, things that you want to make sure that we know about before we close up today? We always meet on the first Wednesday of the month, same time, same place. So please join us next month. And we want to be engaging and talking on Basecamp. So please get involved in Basecamp, ask questions there, look at resources. We share slides. The recordings are now on YouTube because we are a SIG for the CFHA. So lots of ways to access this information.
There's a question about the spring. Oh, I'm sorry. Go ahead, Tisha, if you were going to.
Oh, go ahead, Marka, because I don't really know the details.
I was going to punt it to Hannah, who was on the call, about the spring virtual conference and details that are there.
Yes, the spring virtual conference is April, I believe, 17 and 18. Registration did open just a couple days ago. I can try and quickly pull up the link, but it's on our website and also in the newsletter that Liana sends out. Was there another more specific question about it?
Nope, I think that was it. Thanks, Hannah.
Perfect.
Okay, well, we will see everyone on base camp in the interim, and we will see everybody at the first Wednesday of March. Thank you very much, everyone. Have a great rest of your Wednesday. Thank you, Laura.
Laura,
That was
send
great.
me over your PowerPoint so I can put it in base camp for everybody.
Sounds great. Thanks, Monica. I'll do that.
All right.
Yeah. Thank you so
Bye,
much, Laura.
everybody.
That was great.